Welcome to the Deep Dive. We sift through stacks of sources, pull out the really key insights, and, well, give you a shortcut to being genuinely well-informed.
And today we're diving into something that affects so many people, yet it's still deeply misunderstood.
Exactly. Depression, when you hear that word, the first thing that probably pops into your head is just feeling sad.
Right. Yeah, simple sadness.
But the reality, and this is kind of the core insight we're unpacking today, is that it's way more complex. It's layered. It's unique to each person. It's not just having the blues.
Absolutely. It really does have many faces. And our mission here, drawing a lot from Dr. Diane McIntosh's book, This is Depression, is to sort of peel back those layers for you.
Yeah, give you the clearest, most impactful understanding of what depression really is.
From how it's diagnosed, how it shows up differently in different people.
Its underlying causes, which are fascinating.
And importantly, the different paths people take towards recovery.
So whether you're listening to understand it for yourself, maybe for someone you care about, or you're just curious, well, this deep dive is really for you. Let's get into it.
Okay, so defining depression. We really need to move past just feeling sad. The key thing for a clinical diagnosis, it's what's called functional impairment.
Functional impairment. Okay, what does that mean in practical terms?
It means the person just can't carry out their normal daily activities. You know, the things needed for basic needs, responsibilities, just general well-being. It gets in the way.
So it's not just the feeling, it's the impact of the feeling on your actual life.
Yeah.
That's a big distinction. Does the DSM-5, the diagnostic manual, spell this out clearly?
It does provide a blueprint, yeah. For a major depression diagnosis, the DSM-5 says you need at least 5 out of 9 specific symptoms.
5 out of 9.
And here's the kicker. One of those 5 must be either a depressed mood, like feeling down most of the day, nearly every day, or a real loss of interest or pleasure in, well, pretty much everything you used to enjoy. Anhedonia.
Anhedonia. Got it. And the other 7 symptoms that could make up the 5.
Right. Those include things like big changes in sleep, sleeping way too much or way too little.
Okay.
Significant changes in weight or appetite, feeling really restless and agitated, or the opposite, feeling really slowed down, like moving through molasses. Persistent fatigue, like bone-deep tiredness, feelings of worthlessness or excessive inappropriate guilt.
That sounds tough.
Yeah. Difficulty concentrating, thinking, making decisions, and recurrent thoughts of death or suicide.
Wow. Okay, so when you combine those 9 symptoms,
Yeah.
5 needed, one has to be mood or interest.
Exactly. You end up with, and this is pretty astonishing, close to 1,000 different ways depression can actually be experienced.
Nearly 1,000 combinations.
Right.
That's mind-boggling. It really shatters that idea of depression being just one thing. It's incredibly personal.
It really is, which is why it can be so hard sometimes for people to even recognize it in themselves, let alone explain it.
Yeah, I can see that. Maybe an example would help illustrate this.
Definitely. Let's take Sven. He's a 46-year-old professor, award-winning, loved his job, on track to be department head. Suddenly, he tries to resign.
Out of the blue.
Seemingly. But looking back, for months, he lost all interest in his work, became really irritable, short-tempered. He couldn't focus on marking papers, couldn't pay attention in meetings. He was sleeping badly, worrying constantly, just exhausted all the time. That's functional impairment right there, disrupting his whole career, his life. And his symptoms were that specific mix for him.
Sven's story really shows how it can affect anyone, even someone seemingly at the top of their game, and how hidden it can be.
Exactly.
Beyond those core symptoms you mentioned, it shows up in surprising ways, like physically.
Oh, absolutely. Let's talk sleep first. It's common, but it varies hugely. You've got insomnia trouble, falling asleep, staying asleep, or waking up way too early.
Right.
But then there's the flip side, hypersomnia. Wanting to sleep constantly, maybe 12, 14 hours, struggling to get out of bed.
But still feeling tired.
Still feeling utterly exhausted. That's the key. Whether it's too little or too much sleep, it's rarely refreshing sleep.
Okay, that makes sense. And the physical stuff, you mentioned actual pain.
Yes, the mind-body connection is so strong here. Depression can cause somatic symptoms, real physical feelings, pain, nausea, diarrhea, dizziness, headaches, muscle aches, tension.
Wow.
It can worsen existing pain or even create new pain that doctors can't find a clear medical cause for.
Like that story of Mrs. Gupta.
Exactly. Chronically upset stomach after her husband died. Doctors ran tests, found nothing. Turns out her deep sadness and constant worry were manifesting physically. Her body was expressing the distress her mind couldn't, or maybe wasn't allowed to, fully process.
It's a powerful reminder to listen to our bodies, isn't it?
It really is. And another big area is cognitive symptoms, thinking problem.
Like brain fog.
Yeah, exactly. Trouble concentrating, poor memory, slowed thinking, difficulty organizing tasks. It can be so significant, especially in older adults, that it sometimes gets mistaken for dementia. They even call it pseudodementia.
Pseudodementia.
Yeah.
That really highlights how tricky diagnosis can be.
Yeah.
And you also mentioned agitation. I usually picture fatigue with depression.
Fatigue is very common, yes. But some people experience the opposite, a profound sense of restlessness, being fidgety, agitated, can't sit still.
So they might seem anxious.
It can look like anxiety, and often anxiety and depression go hand in hand, which makes getting the right diagnosis even more important.
Okay, so with nearly 1,000 potential presentations, it makes sense there isn't just one type of depression. You mentioned atypical depression. The name sounds, well, atypical.
Right. It's a confusing name because despite atypical, it's actually thought to be the most common type of depression and the most hereditary.
Really? Most common. What makes it atypical then?
It often starts earlier, like in the teen years. It's 2 to 3 times more common in women. It tends to be more chronic, persistent, and it's common in bipolar depression too. The key atypical features are often reversed vegetative symptoms.
Reversed vegetative, meaning?
Meaning, instead of insomnia and appetite loss, people experience hypersomnia, sleeping way too much, and increased appetite or weight gain. Their mood might also lift temporarily in response to positive events, which isn't typical of classic melancholic depression.
So sleeping more, eating more, but still deeply depressed. That's crucial to know. What about seasonal depression? Is that just the winter blues?
It's more than just feeling a bit down in winter. Seasonal affective disorder, or SAD, involves recurrent episodes of depression that reliably start and end at specific times of the year, usually onset in fall or winter, remission in spring or summer.
And there are criteria for that too.
Yeah, the DSM-5 requires that pattern to have happened for at least 2 years. It's strongly linked to lack of light, hence why it's much less common closer to the equator.
Okay. And then there's bipolar depression. This seems like a really critical one to get right because misdiagnosis can cause problems.
Huge problems, because the treatment is very different from unipolar depression, which is major depression without mania or hypomania. Think of mood disorders on a spectrum.
Yep.
Major depression at one end, bipolar 1 at the other.
And bipolar 2 and others in between?
Exactly. Bipolar A requires at least one full manic episode.
Mania. What does that actually look like? It's not just happy, right?
Oh, definitely not. It's an abnormally elevated, expansive, or irritable mood. Plus, frenzied activity, inflated self-esteem or grandiosity, very little need for sleep, racing thoughts, talking really fast, distractibility.
That's exhausting.
It is, and often involves high-risk behaviors, uncharacteristic spending sprees, substance use, reckless driving, unsafe sunks. The person might feel brilliant, but to others, they often seem disorganized, even chaotic.
So it's easy to see how that might be missed if someone only seeks help when they're in the depressive phase.
Very common. Which is why stories like Adaisy's are important. 21-year-old student comes in for nonstop worry. But digging deeper reveals these crash and burn moods since high school.
Crash and burn.
Yeah, feeling okay, then suddenly wanting to die. These downtimes lasted weeks, sleeping 12+ hours but feeling drained, missing classes, gained 20 pounds from late-night eating, extremely irritable, even throwing things.
Wow. Any other clues?
Crucially, her mom had similar experiences when younger. That family history, plus the clear swings between highs, maybe not full mania, but significant shifts and lows, pointed towards bipolar disorder, not just major depression. Getting that distinction right is vital for effective treatment.
Absolutely. Understanding these different phases is step one. But what's actually going on underneath all this? What causes depression?
That's the million-dollar question, isn't it? The best way to think about it is the biopsychosocial model.
Biopsychosocial. Okay, break that down.
It means all mental illnesses, depression included, stem from this complex interplay. Biological factors like genetics and brain chemistry, psychological factors like personality and coping styles, and social factors like relationships and environment. They all weave together.
So it's never just one thing.
Rarely, if ever. Let's start with biology. Genetics definitely plays a role. Mental illnesses often run in families.
We hear that a lot. Do we know which specific genes?
We're still learning, but one gene that's gotten attention is SLC6A4. It codes for the serotonin transporter. Think of it as the brain's serotonin cleanup crew.
Okay, the cleanup crew.
Some people inherit versions, like the short variation, that make this crew maybe a bit too efficient. Serotonin gets cleared away too quickly. This is linked to higher rates of anxiety and depression.
Fascinating. So genetics sets a predisposition, and neurotransmitters themselves, like serotonin.
They're crucial. These chemical messengers regulate everything from mood to sleep to appetite. For depression, the main players we focus on are serotonin, norepinephrine, and dopamine. Most antidepressants target these systems.
Right.
But we're also learning more about others, like glutamate and GABA. It's complex chemistry.
And hormones. You hear that women are more likely to experience depression, especially after puberty.
That's true, about twice as likely. Estrogen seems to be a key factor. Its levels surge at puberty and fluctuate throughout life, directly impacting brain areas involved in emotion, often interacting with serotonin and stress hormones like cortisol.
Cortisol, the stress hormone. How does chronic stress fit into this biological picture? It sounds like it could create a vicious cycle.
It absolutely can. When you're under prolonged stress, your body pumps out cortisol constantly. Eventually, your brain can become insensitive to it. Like a smoke detector that's always going off, the brain starts to ignore the signal.
Okay, so the stress response gets dysregulated. Then what?
This cortisol insensitivity triggers inflammation. It activates immune cells in the brain called microglia and increases inflammatory molecules called pro-inflammatory cytokines, or PICs. You get inflammation in the brain.
Brain inflammation. That sounds serious. How common is that in depression?
It's found in about half of people with depression and maybe up to 80% in severe treatment-resistant cases.
Wow, so depression isn't just in your head. It can involve actual physical changes in the brain.
Exactly. And after someone has had 3 or more episodes, depression can start to look more like a chronic inflammatory illness. It becomes harder to treat, more likely to come back, and we even see structural brain changes and worse cognitive symptoms.
That sounds daunting. But you also hear about neuroplasticity, the brain's ability to change. How did that fit in? Is it always good?
Neuroplasticity is the brain's amazing ability to reorganize itself, but it can be a double-edged sword. In depression, repetitive negative thoughts, "I'm worthless, nothing will ever get better," can actually strengthen those negative pathways. That's bad neuroplasticity. The brain gets wired for negativity.
So you get stuck in a rut, literally neurologically.
Kind of, yeah. But the hopeful part is good neuroplasticity. Our brains can also form new, healthy connections. This relies heavily on a molecule called BDNF, brain-derived neurotrophic factor.
BDNF, what does that do?
Think of it as miracle grow for brain cells. It's like fertilizer. Produced by helper cells called astrocytes, it helps grow new neurons and protects existing ones.
And in depression.
BDNF levels are often low in depression. This might contribute to the illness and make recovery harder. Low BDNF is also linked to things like Alzheimer's and poor stress resilience. So boosting BDNF becomes a potential target for treatment.
So we want to encourage the good neuroplasticity, the BDNF production. This links biology to experience too, right? What about early life and epigenetics? That sounds like our experiences can actually change our genes.
Not change the genes themselves, but change how they're expressed, whether they're turned on or off. That's epigenetics. Think of your DNA like a giant piano keyboard. Everyone has their unique set of keys.
Okay.
Epigenetics is like the sheet music or the pianist, determining which keys get played, how loudly, and when. Experiences, especially early ones, can rewrite that music.
Can you give an example?
There are famous studies with rats. Pups raised by nurturing mothers who licked them a lot grew up to be less anxious. This nurturing actually caused epigenetic changes in genes related to stress response. And incredibly, these changes could even be passed down.
Wow. So good parenting literally changed their stress wiring.
Exactly.
Right.
And conversely, pups raised by neglectful mothers showed different epigenetic patterns and were more anxious. It suggests that early environments, abuse, neglect, but also love and security, can leave a lasting imprint on how our genes function throughout life.
That has huge implications. It connects biology right back to the psychological and social factors.
Precisely. It's all interconnected.
So moving to those psychosocial factors, what about personality? Does that play a role?
It seems to. High levels of neuroticism, a personality trait characterized by sensitivity to negative emotions like anxiety, anger, and sadness, are strongly correlated with a higher risk for depression and anxiety disorders.
Okay. And social support, having people around you.
Hugely important. A strong social support network is definitely protective. But interestingly, the research suggests the key factor isn't just the number of friends you have.
No. What is it then?
It's the belief that you have people you can count on. That feeling of perceived support, knowing someone has your back if you need them, seems to be more critical than the actual size of your network.
That makes sense. It's about feeling connected and secure. What about stress from societal factors, like discrimination?
Yeah, the minority stress model is really relevant here. It explains how experiences of prejudice, discrimination, harassment, and abuse faced by racial, ethnic, sexual, or gender minorities create chronic stress.
And that increases vulnerability.
Exactly. It leads to alienation, constant vigilance, internalized negativity, and ultimately higher rates of mental and physical health problems. Plus, these groups often face significant barriers in accessing good quality healthcare.
So disparities in care are a big issue.
Huge. Data consistently shows lower rates of adequate mental health treatment for Hispanic, African American, Latinx, Asian American, and Native American individuals compared to white individuals. And even with growing societal acceptance, sexual and gender minorities still face high levels of discrimination, leading to stress and healthcare avoidance.
It paints a picture of how deeply societal structures impact individual mental health. And this ripples outwards, right? You mentioned the economic cost, especially at work.
Oh, definitely. The focus is often on absenteeism, people taking sick days. But the far bigger economic drain, estimated to be 6 times costlier, is presenteeism.
Presenteeism, being there but not really there.
Exactly. Showing up to work while depressed, but being unable to concentrate, be productive, make decisions. You're physically present, but your capacity is significantly reduced. It's a massive hidden cost to employers and economies.
That's a powerful statistic. Okay, we've explored the complexity, the causes, the impact. Now let's talk about the journey towards help. What's the first step if you suspect someone is struggling or if you are struggling yourself?
You know, the simplest, yet maybe the most profound thing, just listen.
Listen.
Yeah, Dr. McIntosh uses this great analogy. Depression is like an abscess. It's painful, it's full of toxic stuff, and you can't just snap out of it or wish it away. It needs to be drained. Listening, truly hearing someone without judgment, can be the start of that process.
But people might be reluctant to talk.
Very often. Fear of rejection, lack of energy, this deep conviction that nobody cares or could possibly understand. So creating that safe space to listen is crucial.
Okay, so if someone is ready to seek help, how do they actually approach their doctor? It feels like a really hard conversation to start.
It can be incredibly daunting. Think of Desiree. She booked an appointment for back pain, but just broke down when the doctor asked, "How are you doing?"
Yeah.
My advice, be direct if you can. Say something like, "I've been feeling sad and down for a few months," or "I've lost interest in things." List your symptoms. It's also totally okay to say, "I read about depression and I think I might be experiencing it."
So naming it is okay.
Absolutely. You can even fill out a screening questionnaire beforehand, like the PHQ-9, and bring it with you. It gives the doctor concrete information to start with.
What if the depression itself makes it hard to even organize your thoughts or remember things for the appointment?
That's where bringing a trusted friend or family member can be invaluable. They can provide collateral information, observations about how you've been doing. This is especially vital if someone has lost insight, meaning they don't fully recognize they're ill, which can happen in severe depression or bipolar disorder.
Right. And remember, the doctor is there to help.
Exactly. It's their professional responsibility to assess you properly and either start treatment or refer you to a specialist like a psychiatrist. You don't have to have all the answers yourself.
These are really practical tips. Once someone is working with a mental health professional, what are some priceless pearls, as Dr. McIntosh calls them, for making that relationship effective?
Engagement is key. Be an active participant and try to be informed. If cognitive issues make it tough, maybe dictate your symptoms and how they're impacting you to a friend who can write them down point form for your appointment.
Good idea. What about boundaries in therapy? That seems important.
Extremely important. The therapeutic relationship has firm ethical boundaries, and this needs saying clearly. No sexual relationship or contact is ever acceptable between a therapist and client, period. Terminating therapy to start a romantic relationship is also unethical due to the power imbalance. These rules protect the patient.
That's a crucial clarification.
Yeah.
What about boundaries outside therapy? Managing questions from others if you've been unwell.
You don't owe anyone your private medical details. If someone asks intrusive questions about why you're off work or missed events, a simple, "I had a medical issue I was dealing with," is enough.
And if they push.
Dr. McIntosh humorously suggests saying explosive diarrhea usually stops further questions, but seriously, a polite but firm "that's private" works. Strong boundaries are healthy. You control who you share with. And importantly, if you're supporting someone, remember your own boundaries and self-care too.
Very true. What about the incredibly difficult situation where a loved one clearly needs help but refuses it?
That's heartbreaking and frustrating. The reality is, you usually can't force an adult to get treatment unless they're in immediate danger to themselves or others, which might involve legal steps, especially if they've lost insight into their illness.
So what can you do?
Keep gently encouraging them. Offer practical support, like offering to go with them to an appointment. Make sure they know about helplines for immediate confidential support. But you can't force it, and that's a painful reality sometimes.
Yeah. And navigating work while depressed.
Yeah.
We touched on presenteeism. Just getting out of bed can be a struggle, let alone performing at a job.
It's immensely challenging. The fatigue, the lack of motivation, the cognitive difficulties, it often leads to underperformance, which then feeds the feelings of worthlessness. It's a tough cycle.
So taking time off work might be necessary.
It often is. That decision should always be made with your doctor or therapist. They can provide the necessary documentation. You don't need to disclose details to your supervisor. HR can help manage the process confidentially. Your boss doesn't have a right to your specific diagnosis.
But taking time off isn't a cure-all, right? There's a balance.
Absolutely. Critical point. While time off can be essential for recovery, the evidence is clear. Returning to work as soon as symptoms allow is really important. The longer someone is off work, statistically, the less likely they are to ever return.
That's a sobering thought. So reintegration is key, despite potential stigma.
Yes. Facing potential awkwardness or perceived stigma is hard, but getting back into routine and structure is often a vital part of consolidating recovery.
Okay, let's shift to treatment options. What are the overarching principles people should know?
First, there's no recipe. Treatment has to be personalized. It takes time, effort, sometimes trial and error, and creativity from both the patient and the clinician.
And the goal.
The goal is full recovery, feeling and functioning like you did before the illness. And critically, feeling like a zombie is never an acceptable outcome. If a treatment makes you feel numb or emotionally blunted, that's not success. Speak up.
That's empowering. What about medication? There's still a lot of stigma.
Yeah, fueled by misinformation. But appropriate medication, when needed, is compassionate, often highly effective, and sometimes genuinely life-saving. It's a medical treatment for a medical illness.
And hope is important.
Hope is crucial. Never, never, never give up. Patients fight internal battles daily, maybe questioning if they should take their meds, dealing with side effects. But the alternative, untreated or undertreated depression, is devastating. Keep seeking solutions.
Good advice. What about understanding medication approvals and doses?
Regulatory agencies like the FDA or Health Canada approve drugs for specific uses based on trials. This info is in the product monograph. Sometimes doctors might prescribe off-label or use doses outside the standard range based on clinical experience, but they should always explain their reasoning and always, always discuss potential side effects, short and long term, so you can make an informed choice.
Let's talk specifics. Antidepressants, big one.
Right.
Are they addictive?
Okay, crucial clarification. Antidepressants are not addictive in the way we think of substances like opioids or stimulants. They don't cause craving or euphoria.
But people talk about withdrawal.
They can cause discontinuation symptoms if stopped abruptly, especially older ones like Paxil or Effexor XR. These can be unpleasant, like dizziness, nausea, brain zaps. That's why you always taper off slowly under medical guidance. It's not addiction, it's the body readjusting.
Okay, that's a key difference. How do they actually work?
Most work by affecting neurotransmitters. They block the reuptake, the recycling process of chemicals like serotonin or norepinephrine in the synapse, the gap between nerve cells. This leaves more neurotransmitters available to send signals. Over time, the brain adapts to this new chemical environment.
Makes sense. What about common side effects people worry about? Sexual dysfunction.
Yeah, that's a big one. Very common with many antidepressants, especially SSRIs and SNRIs, and often persists. It's a major reason people stop taking them. Strategies exist, lowering the dose, switching meds, adding another medication, but it needs open discussion with a doctor. Mirtazapine and bupropion XL tend to have lower risk.
And emotional blunting, feeling numb.
Also a significant issue, again, often linked to SSRIs or lower doses of SNRIs, feeling like you can't cry or feel joy. The strategies are similar. Switch to a lower-risk drug, maybe increase the SNRI dose if appropriate, or add something that boosts norepinephrine and dopamine. Feeling flat is not the goal.
So communication is absolutely key. Can we quickly run through the main classes? SSRIs.
SSRIs, selective serotonin reuptake inhibitors, very common first line. Think fluoxetine, Prozac, escitalopram, Lexapro, sertraline, Zoloft. Fluoxetine has good data for youth, FDA approved down to age 8. Paroxetine, Paxil, is maybe noted for higher risk of weight gain, sexual side effects, and discontinuation issues.
Okay, SSRIs.
Serotonin or norepinephrine reuptake inhibitors, also very common. Venlafaxine, Effexor, duloxetine, Cymbalta,
Yeah.
generally safe, effective, and can sometimes help with chronic pain, especially at higher doses. Similar side effect profile, often potential for weight gain, sexual issues, sleep changes, sweating, maybe increased blood pressure.
I know that the older ones, MAOIs.
Monoamine oxidase inhibitors. They're effective, sometimes very effective for difficult cases, but they come with a serious dietary restriction. You must avoid foods high in tyramine-aged cheeses, cured meats, some beers, and wines.
Why?
Because the MAOI stops tyramine breakdown, and high levels can cause a hypertensive crisis, dangerously high blood pressure, potentially fatal. So they require significant commitment and caution.
Definitely something to take seriously. Atypical antipsychotics. Using antipsychotics for depression sounds counterintuitive.
It does, but several AAPs, like aripiprazole, Abilify, or quetiapine, Seroquel, are approved as add-on treatments for treatment-resistant depression, TRD. They often help with both depressive and anxious symptoms, usually at much lower doses than used for psychosis. A side effect to watch for is akathisia, that awful inner restlessness.
Okay. And benzodiazepines like Valium or Xanax, they get the bad rap sometimes.
They do, often unfairly vilified. But Dr. McIntosh argues they can be compassionate short-term tools. Used carefully for maybe 1 to 3 months alongside an antidepressant, they can quickly reduce severe anxiety or agitation, helping someone tolerate the initial phase of antidepressant treatment or get through a crisis.
So not usually a long-term solution for depression itself.
Generally not for depression alone, no. They have side effects like sedation, cognitive slowing, especially in older adults, and potential for dependence with long-term use. But for short-term, targeted relief of overwhelming anxiety during depression treatment, they can be, as she says, life-saving.
Got it. And quickly, melatonin for sleep.
Natural hormone product helps regulate sleep-wake cycles. Generally well-tolerated, good for things like jet lag or shift work sleep issues, can sometimes help with sleep problems and depression. Quality varies between brands. Start low dose to avoid daytime grogginess. Always best to check with your doctor.
Okay, that covers a lot on medication.
Yeah.
What about non-medication approaches? Therapy.
Psychotherapy, or talk therapy, is a cornerstone of treatment, often used alongside medication, especially for moderate to severe depression. Many different types exist: CBT, interpersonal therapy, psychodynamic therapy.
Does the type matter most?
Research suggests the specific type might be less important than the therapist's skill, the patient's characteristics, and crucially, the therapeutic relationship. That alliance, the trust and connection you build with your therapist, is a huge predictor of success. Find a licensed professional you click with.
Can you give a quick flavor of a couple of common types? CBT?
Cognitive behavioral therapy focuses on identifying negative or distorted thought patterns and beliefs that contribute to depression and learning skills to challenge and change them. And changing behaviors, too. Like Jojo, the accountant who felt like a failure after being passed over for promotion CBT, would help her examine and reframe that all-or-nothing thinking.
And behavioral activation.
BA is simpler, based on the idea that depression often leads to withdrawal and avoidance, which makes things worse. BA helps people gradually schedule and re-engage in positive or meaningful activities, even small ones, to counteract that withdrawal and hopefully improve mood. Activity itself becomes the intervention.
Makes sense. Mindfulness.
Yeah, mindfulness practices, learning to pay attention to the present moment without judgment, are increasingly integrated into therapy. Can be learned via therapists, books, apps. One patient found a 5-minute guided meditation app really helpful to use at work during stressful moments.
Great examples. What about treatments that directly stimulate the brain? Neurostimulation.
Right, these really highlight depression as a brain illness. Electroconvulsive therapy, ECT, is the oldest but still considered the gold standard for severe, life-threatening, or treatment-resistant depression.
It has a scary reputation, though.
It does, largely due to outdated portrayals. Modern ECT is much safer, done under anesthesia with muscle relaxants. It's incredibly effective, often works much faster than meds for severe cases. The main side effect concern is memory loss, which is usually temporary but can sometimes be more persistent. But for many, it has been life-saving when nothing else worked.
Okay, what about TMS? magnetic stimulation.
Repetitive transcranial magnetic stimulation, RTMS, uses magnetic pulses to stimulate specific brain areas involved in mood. It's non-invasive, doesn't require anesthesia, usually reserved for people who haven't responded to meds or therapy. It's generally well tolerated. Common side effects are scalp discomfort or headache during treatment. Not suitable for people with seizure history or metal in their head.
Interesting. And finally, lifestyle and supplements. Do they have a real role?
Absolutely. Exercise has strong evidence beneficial for pretty much every depressed person. Doesn't have to be intense marathon running, just regular movement. Yoga also shows benefits. Light therapy is key for SAD. Some non-prescription options have decent evidence, like omega-3 fatty acids, fish oil, SAMe, and St. John's wort. But crucial caveat, natural doesn't mean harmless. St. John's wort especially can have serious interactions with many medications, including antidepressants and birth control pills. Always talk to your doctor before starting supplements.
Good warning. What about cannabis? It's everywhere now. Lots of claims about helping depression.
Yeah, it's a really controversial topic. Dr. McIntosh points out that the current scientific evidence is actually pretty weak for cannabis helping depression. In fact, non-medical use might even hinder recovery, reduce help seeking, and is linked to higher rates of suicidal thoughts and other psychiatric issues in some studies.
So the hype might be ahead of the science.
It seems that way for depression specifically. There's a lack of high-quality trials. Anecdotal reports aren't enough. Generally, it's not recommended as a primary treatment, may be considered only after conventional treatments have failed, and always with careful medical guidance, not self-medicating.
That's a really important counterpoint to the common narrative. Okay, we need to address a very difficult but vital topic: suicide.
Yes. It's crucial to talk about. The stats are alarming. Suicide rates increased significantly in many places over the last couple of decades. It's complex, not just a symptom, but often something that develops over time as pain becomes overwhelming and suicide starts to feel like the only escape.
And challenging the myth that it's selfish.
Absolutely. In Dr. McIntosh's experience, people contemplating suicide are usually trying to end unbearable pain and often feel they're actually freeing loved ones from the burden they perceive themselves to be. It comes from a place of profound suffering, not selfishness.
It's important to understand that perspective. There's a difference between thinking about it and acting on it.
Yes. We distinguish passive suicidal ideation, wishing you were dead but no plan, from active suicidal ideation, wanting to die and having a specific plan. Then there's suicidal behavior, acting on those thoughts with intent to die.
The stats for young people are terrifying, second leading cause of death for 15-29-year-olds globally in recent years. What makes someone more likely to move from thoughts to action, suicide capability?
Several factors increase capability. Becoming less afraid of death and pain, perhaps through exposure to violence or previous self-harm. Having access to lethal means is a major factor, and exposure to suicide or self-harm in others, unfortunately.
This brings us back to the SSRI black box warning controversy. The warning about increased suicidal thoughts in youth on antidepressants caused huge fear.
It did. The FDA warning highlighted a small increase in reported suicidal thoughts or behaviors, around 4% on SSRIs versus 2% on placebo, in analyses of youth trials.
But what's the bigger picture?
The bigger picture, from numerous large reviews since then, is that for moderate to severe depression or anxiety in young people, the benefits of SSRIs clearly outweigh this small risk. Importantly, in those original trials, there were no completed suicides among the thousands of kids taking the SSRIs, and population-level data suggests areas with higher antidepressant prescribing actually have lower youth suicide rates overall.
So the warning might have had unintended negative consequences.
That's the concern. After the warning, antidepressant use in young people dropped significantly. Diagnoses also seemed to decrease, but there wasn't a corresponding rise in therapy use, so potentially kids who needed treatment weren't getting it, possibly due to fear generated by the warning. It's a complex issue with real-world impact.
A sobering lesson in risk communication. So bottom line, if someone is struggling with suicidal thoughts or you're worried about a loved one, what's the most important thing to do?
Reach out. If you're struggling, tell someone, a friend, family member, doctor, therapist, helpline. As one patient powerfully said, you are not alone and you are not damaged. This is absolutely not your fault, so please talk to someone and get help.
And if you're the loved one?
Gently but persistently encourage them to seek professional help. Offer practical support. Make the call with them, go to the appointment, know the numbers for local crisis lines or national suicide prevention lifelines, provide immediate, non-judgmental support. Ask directly, are you thinking about suicide? It doesn't plant the idea, it opens the door.
That's vital advice. This has been such an important deep dive. We've covered so much: the many faces of depression, the complex biopsychosocial roots, the journey to getting help, the wide range of treatments.
And the key takeaway, I think, despite the seriousness, is hope. Depression is treatable. Recovery is possible. It takes work, persistence, the right support, but it is achievable.
Absolutely. And maybe a final provocative thought to leave our listeners with.
Going back to the brain science, remember neuroplasticity and BDNF. Here's the thought. We have the power to grow new brain cells and rewire our brains throughout our entire lives. Recovery from depression isn't just something that happens to us. It fundamentally depends on harnessing that incredible capacity of the brain to heal and change.
Wow, that puts agency right back into the recovery process.
Yeah.
A really powerful note to end on. We hope this deep dive is giving you a richer, more nuanced understanding of depression. Keep exploring, keep learning. Thanks for diving deep with us.